Good morning, everyone. Welcome to Retina Imaging Conference. I'm Abtin Shahlaee. I'm one of the first-year Retina Fellows. I'll be presenting today's cases. Our first case is that of a 56-year-old gentleman presenting with floaters and blurry vision in the left eye for approximately 3 days. Dr. Light, could you walk us through this case?
Sure. So wide field pseudo-color imaging of the right eye, 20/25 vision here. Media looks clear. The disc margins are sharp. No edema. The vasculature, at least proximally, looks to be of normal course and caliber. A little bit harder to visualize. Maybe the most peripheral arterioles might be a little bit attenuated. The macula itself looks clear. No hemorrhages, no lesions. There is this focal, perhaps hypopigmented chorioretinal scar, area of atrophy out here in the infratemporal periphery, but otherwise the remainder of the fundus looks normal.
Excellent.
On the contrary, in the left eye, vision here 20/40, this is the symptomatic eye. Clearly, the media is not clear. There is what appears to be significant amounts of vitreous hemorrhage throughout, more prominent inferiorly than superiorly. Difficult to visualize the disc margins here, unclear if that's due to underlying edema or possibly could just be from the overlying vitreous haze. The macula is without any lesions. Again, poor view though through the vitreous opacities. The vasculature itself, where visualized, appears to be roughly of normal course and caliber. Again, poorly visualized inferiorly. Attention is drawn to this focus here, just supranasal to the disc, where this appears to look like a subretinal hemorrhage, though there's a focus here of lighter color that may be a part of breakthrough or maybe intraretinal, hard to say from the imaging. In the far periphery, again, no lesions or abnormalities that I can see here.
And we did think there was an intraretinal component to it on the clinical exam. This is the earliest FA that we have.
Yeah, so fluorescein angiography of the left eye at 49 seconds. Again, you can tell that the media opacity is obstructing quite a bit of the image here. This appears to be full AV phase at this point where the vasculature is visualized. There is this large area of blockage. And you can tell that this is likely subretinal given the fact that you are able to visualize some vessels overlying it. And there is this kind of punctate focus of maybe early hyperfluorescence here, roughly corresponding to that intraretinal component that we were talking about on the pseudocolor. Moving along to 1:08 seconds, again, left eye, still AV phase. Again, you can see the blockage here, this hyperfluorescent focus at that location. There are also possibly some microaneurysms out here in the far periphery nasally. Unclear if that's leakage or if this is just a little bit out of focus here, but I would keep an eye on that area. 2 minutes, 53 seconds. Slightly better visualization of the periphery here. You can see maybe there's some window defect out here nasally. Again, these scattered microaneurysms. The appearance of this area of blockage is overall unchanged. Hard to say. I'm not sure that I see any leakage here at this hyperfluorescent focus. It looks to be fairly stable in size. And then at 4 minutes, 25 seconds, again, kind of similar appearance with the scattered microaneurysms. This, again, looks like staining or window defect here. Similarly, nasally. And again, no increase in the size of the lesion that was, the hyperfluorescence that was noted prior.
The asymptomatic eye.
So fluorescein angiography of the right eye at 1 minute, 36 seconds. Again, we are in full AV phase here. Similar findings as those seen in the in the left eye, where there are these scattered microaneurysms, maybe a touch of non-perfusion out here in the far temporal periphery, these well-circumscribed staining versus window defect areas here, but no leakage, and the macula and the blood vessels proximally look within normal limits. And a later frame, I think, just redemonstrates essentially the same findings, no leakage. This is a ICG angiography, I'm assuming of the left eye, given all the media opacity here. Overall, the choroidal filling looks good. There is, again, some blockage in this area that was suspected to be subretinal hemorrhage. And there is some slight hypercyanescence right at that focus that we were suspecting might be intraretinal, but no polyps or other deep choroidal lesions. And late frame, 4 minutes, 28 seconds, again, we don't see any prominent polypoidal-like leakage in this area. And ICG of the right eye at 1 minute, 40 seconds, looks very good, intact, full choroidal perfusion. Retinal vessels as well look within normal limits, no leakage. And similarly at a later frame, 4 minutes, 8 seconds. This is a EDI OCT scan of the right eye through the fovea. The choroid appears to be of normal thickness. Outer retinal lamination patterns are intact, as are inner retinal lamination patterns, good foveal contour, and clear vitreous. And again, regular B scan through the horizontal B scan through the fovea in the right eye, again, shows normal retinal lamination patterns throughout. And an EDI scan through the fovea of the left eye, again, limited by some shadowing artifact, presumably from the vitreous opacities, a normal choroidal thickness, and where visualized, the retinal lamination patterns appear to be intact without disruption. There, you can see there's probably some vitreous opacities here, more noticeable temporally.
A few cuts traversing through the macula.
Yeah, so this is a superior macula. It appears on the en face. You can clearly see the vitreous opacity suspected to be hemorrhage there, reflected here as well in the B scan with these hyperreflective punctate foci in the vitreous. Healthy nerve fiber layer, inner retina, outer retina, and choroid all appear to be of normal appearance. And similarly, vitreous opacity here, good foveal contour, no intraretinal lesions. And same on the inferior macula.
So given the constellation of our findings here, what would be on your differential?
Yeah, so we have unilateral acute onset of what appears to be multi-layered retinal hemorrhages, including some breakthrough vitreous hemorrhage. The things I would be thinking about, in particular with the subretinal hemorrhage, choroidal neovascularization, whether it be age-related or polypoidal or perhaps degenerative, like from myopia, though, again, this patient's fundus doesn't look all that myopic. We didn't see any polyps on the ICG definitively. Other things you could think about would be like a Valsalva retinopathy, can cause multi-layered hemorrhages. Leukemic retinopathy as well can do this, though it would be unusual to be, I think, unilateral to this extent. Another thing to think about would be like Terson syndrome, so get a history of any head trauma, subarachnoid hemorrhage. That can also cause a picture like this. And then I think retinal arterial macroaneurysm with some breakthrough hemorrhage into the vitreous would be a high consideration, especially given that intraretinal component.
Excellent. So you hit on all of what we were thinking about. Just given the clinical appearance, our primary concern was for a RAM in this patient, but as you alluded to, causes of multi-layered hemorrhages, including Valsalva retinopathy, leukemia, Terson syndrome. If it were a child, obviously non-accidental trauma, though it would be strange for it to be unilateral like this, or in our differential, as well as causes of peripapillary CNVM. So regarding the patient's history, he didn't have any positive ocular history, no known refractive error. He did have significant cardiovascular risk factors, including hypertension, hyperlipidemia, a history of MI, obstructive sleep apnea, and interestingly, he had pretty severe coughing episodes in the days leading to him becoming symptomatic. He was on a host of cardiovascular medications, just aspirin regarding blood thinning agents, and he had a very strong positive family history for hypertension and cardiovascular disease and was an active smoker.
Abtin, I just want to point out that although an aneurysm certainly is very high differential to explain the hemorrhaging, the symptoms and so forth, we can't ignore the peripheral microaneurysms in both eyes. So something else is going on.
So given the clinical presentation, I guess apart from the peripheral microaneurysms, our primary diagnosis here was retinal artery macroaneurysm, which is a acquired dilatation of the retinal arteries, and it commonly occurs at the sites of arterial bifurcations and AV crossings, and most commonly it occurs along the temporal arcades, though in our case we saw it nasally. The occurrence of multiple aneurysms of bilateral lesions tend to be relatively rare, and this is a condition that occurs most commonly in elderly patients, especially women with a strong female preponderance, the majority of which have significant cardiovascular risk factors, the most common of which being hypertension. So the management strategies for RAM lesions include a host of different options, ranging from observation, anti-VEGF therapy, laser treatment, and pneumatic, including surgical options for evacuating the clot with and without TPA. Presuming the RAM was the cause of this patient's hemorrhage, I wanted to ask the attendings what their treatment paradigm would be here, given that we have a non-macular involving lesion, but the patient does have vitreous hemorrhage and is symptomatic.
Most of the time you can watch this and it should resolve. Obviously, if it doesn't resolve, it's just like a diabetic vitreous hemorrhage, you can go back and clear it out. Typically with the macroaneurysms that are bleeding without exudates and manifestation like that, you don't even have to do a laser. They'll just auto close and the subretinal hemorrhage will go away. You can consider giving anti-VEGF as an additional treatment, but most of the time I'll just watch, especially since it's nasal.
Usually these things only bleed once, so the hemorrhage that's there is likely to settle pretty quickly, and chances are nothing needs to be done. As Aaron mentioned, if it's just bleeding, there's no real treatment to the aneurysm itself that's necessary. It's just a matter of whether you're going to do a vitreous hemorrhage, a vitrectomy for vitreous hemorrhage if it's non-clearing. But anti-VEGF really only has a role if there is persistent macular exudation, and laser too could possibly be used in that setting. Again, that's really for lipid and fluid in the macula that's persisting in the presence of an aneurysm, usually along the temporal arcades.
Yeah, and with the exudates, just along the supratemporal infratemporal arcade, direct or indirect laser around the macroaneurysms really work very well. Even when there's exudates coming in, you can dry it up pretty well with or without the anti-VEGFs.
And what type of laser would you use? Argon?
Yeah, argon green, 200, 200, 200, and you can just usually surround it rather than treating it directly. And you got to give, 1 or 2 treatments. It needs like several months for it to totally resolve.
I don't want to word pick, but you use the words presumption, or this vitreous hemorrhage is presumed to be related to the RAM. I mean, in my experience, this is definitely from the RAM. I don't think there's really another option here, given the fact that the right eye looks, this is not a proliferative diabetic retinopathy state. The other part of management, which we're not talking about, which is very important, is systemic management. That's by far the most important thing. And also, as Dr. Regillo mentioned, to find out why they have these microaneurysms in both eyes. I've never had really any experience with surgical evacuation with TPA. I don't know if there's a role there. Surgical evacuation, yes, but with TPA, I don't know if there's really much value with that.
Yeah, it's unusual to ever need to displace submacular hemorrhage. It'd have to be very large, unusually large, and so forth. And given that the underlying RPE is healthy, thin hemorrhage is usually something that recovers relatively well. Not always, but relatively well.
So this patient was indeed sent to their PCP after their first diagnosis and was placed on an additional antihypertensive medication.
Jose, the microaneurysms peripherally, go back to the fluoresceins, those all go along with hypertensive retinopathy, I presume, right, Jose?
Yeah, I was wondering about that. So I think so, but maybe it would be worthwhile listening to this carotids too.
And no diabetes, I take it? Because sometimes diabetes will present with just peripheral microaneurysms. So rule out diabetes, definitely check the carotids. That's worth doing. There could be underlying ocular ischemia in one or both eyes here.
And there was no diagnosis of diabetes.
I just have a question for the attendings. When you are treating this, with laser, you were saying you surround it, or do you paint it? Kind of like when you treat a microaneurysm in diabetic disease, do you paint kind of right on the vessel, or how do you go about treating
Different
that?
methodology. I mean, you can do it indirectly, just surrounding it. So it takes whitish gray takes on the RPE and the tissue around the macroaneurysm. So some people will take it directly right on the macroaneurysm. I tend to treat indirectly, not directly, but both of them work.
I do a little of both. Yeah, so start around it, sort of get some uptake along the wall of it, whiten it a little bit, and then usually that does the trick.
I do a little bit of both. The way it looks, it determines how I treat it and where it's located, macula versus in the periphery.
Is there ever a concern for inducing an arterial occlusion?
Been reported, and actually, I know a colleague that did that, and so you want it. There's the flow, and we modeled the flow through it is very chaotic, and so it's actually kind of almost a low flow state usually. So you don't need, like my colleagues here are saying, to treat directly on it, but rather around it, because there'll be enough heat that will then go and you just have to tickle around it, basically. There'll be enough heat around it in this chaotic, turbulent flow system to cause some thrombosis in the wall, and that's all you need.
I just wanted to quickly review some of the literature, which is almost completely retrospective in this regard, comparing different treatment modalities. So this is a study comparing laser therapy versus observation in patients with symptomatic RAMS. The choice of treatment obviously was done at the discretion of the physician. And as you alluded to, the laser treatment was done surrounding the lesion as well as to the lesion itself with green argon laser. As one can imagine, the baseline characteristics and vision were lower visual acuity in patients who received the treatment versus those who were elected to get observed. So there was this baseline difference in the cohorts, although it was reported that overall, the patients who were treated with laser had a significantly better visual acuity change comparing laser treatment to the observation group, and there was a subgroup analysis which compared patients who had primarily hemorrhagic lesions versus those who had exudative lesions, showing that patients with hemorrhagic lesions tend to do better in regard to visual acuity gain, whereas those with exudative lesions, there was no difference between the two treatments. This is obviously limited by the retrospective nature that's inherent to this study. There was also a study, this is the largest cohort that I could find retrospectively comparing anti-VEGF treatment versus observation in patients with symptomatic RAMS. And they found that while patients who were treated with anti-VEGF underwent a faster visual recovery, the final visual acuity was no different between the two groups.
Can you go back to the ICG? So I just want to ask my colleagues where this term came from, because this is a fluorescein at 790 and 810. And you're not looking at hypergreening because there is no green at 810. This is hyperfluorescence of ICG. So where did this term hypercyanescence come from? This isn't more green. This is more fluorescence at 810. So just out of curiosity, how did this term come up?
I don't know, I never used it. It's fluorescence, you're right.
So just a follow-up regarding our patient, given that the lesion was non-macular involving, we opted for observation, and after 5 days from initial presentation, the vitreous hemorrhage improved and visual acuity improved to 20/30, and 5 weeks out, there was more significant improvement, vision improving to 20/25, and vitreous hemorrhage almost resolving with substantial improvement in the intraretinal and subretinal hemorrhage. And fluorescein angiogram shows that there's no significant evidence of leakage along the RAM lesion. Do attendings tend to typically take follow-up FAs to look into exudation patterns?
No.
Really, I don't. I mean, you can clinically see if there's going to be exudates or not. So just follow them clinically.
I don't know if I see much value of, of fluorescein on angiogram on presentation either, quite honestly.
Excellent. Okay. Moving
Good
to...
news is the ones that are nasally located very rarely cause significant problems.
Moving on to the second case. This is a 72-year-old female referred for evaluation of quote-unquote macular edema in the right eye. Dr. Sivalingam?
Sure. So we have a wide field pseudo-color fundus photo of the right eye. Vision's 20/40. Media looks clear. Disc margin looks nice and sharp. Cup to disc appears to be approximately 0.4, 0.5. Vasculature looks normal in its coursing caliber. Attention is drawn to these kind of hypopigmented round lesions in the supratemporal macula. And then maybe in the macula here, hard to say for sure because they're pretty zoomed out.
I'll zoom it in a bit.
Oh yeah, this is much better. So here we have this kind of radially oriented, hard to say if it's retinal or choroidal folds. Definitely concerning for some either, I don't know if these are exudates or fluid. OCT would be helpful. And then here we have the left eye, vision's 20/25, media is clear, disc margin looks sharp, cup to disc 0.5, vasculature looks normal in its coursing caliber, macula looks flat. I don't see a similar radial pattern, and then periphery, what's visualized looks relatively normal. Yep, and zoomed in. So yes, I don't see that same radial pattern that we saw in the macula in the right eye. Fundus autofluorescence of the right eye. Macula actually looks relatively normal. Maybe you can see some representation of that kind of radial pattern that we saw here, maybe in the temporal, just temporal to the fovea, and then we have these round hypoautofluorescent areas that correlate to those hypopigmented lesions we saw in the fundus photo. And then left eye, relatively normal. Maybe these kind of punctate foci of hyperautofluorescence, just temporal to the disc and inferiorly here. Macula overall looks normal. So we have an EDI OCT image of the right eye. Looking at the infrared image here, you can more clearly see this radial pattern kind of emanating from the fovea here. And then in the OCT scan itself, vitreous looks nice and clear. Nerve fiber layer looks healthy. Interretinal layers, interplexiform internuclear layer look relatively normal. And then we see this like a separation between, I guess this would be outer plexiform here and outer nuclear layer. The outer retinal layers look normal, and choroid looks normal as well. Another horizontal scan through the fovea, and we can more clearly see this separation here between the outer plexiform and outer nuclear layers. We kind of see these kind of cystoid changes here, and then outer retinal layers look preserved as well.
And the posterior hyaloid is also attached.
Oh, yeah.
Too.
Yep, yeah, you can see that attached here. Yep. Yep, and left eye, horizontal scan, vitreous is clear, inner retinal and outer retinal laminations look normal. Hyaloid is again attached here. Another horizontal scan, looks normal. Maybe some very subtle disruption here in the interdigitation zone, but the visual acuity is normal.
So what would be on your differential?
Yeah, so, initially looking at the color fundus photo, and I see the kind of radial pattern, it almost initially made me think of a macular star. So whenever you see that, I always think of things like neuroretinitis, hypertensive retinopathy sometimes can look like that, especially in the presence of disc edema. However, when you look at the OCT image, you don't see any true exudates to suggest a true macular star in the sense. And the changes we saw in the OCT look more like schisis-like changes. So things that I think about when I see schisis, it'd be nice to know the patient's refraction. Myopic schisis can certainly look like that. Degenerative schisis. Always want to think of things like X-linked retinoschisis. Are there inherited, like autosomal dominant retinoschisis? This is not, it's more schisis and not so much, macular edema, but, non-leaking macular edema. You can think of different medications that can cause that. Niacin and taxanes can cause that as well.
Excellent. So you touched on all the important ones that we had in mind. As Dr. Sivalingam alluded to, our patient didn't really have any symptoms or signs to suggest an exudative process, so I included the differential for foveal retinoschisis. Our patient's demographic fits the characteristics that are described for sniffer, which I'll talk about, but other differentials in this category are X-linked juvenile retinoschisis, which, as the name implies, it's usually in younger males that it manifests, typically a bilateral presentation. For degenerative retinoschisis, our patient didn't really have any manifestations of peripheral involvement or schisis. Regarding enhanced escone dystrophy, there was no evidence of peripheral pigmentary change, and the patient denied any history of issues at nighttime. There was no positive family history to suggest autosomal dominant retinoschisis. The patient was emmetropic, no evidence of myopia or staphylomas on the exam. There wasn't any evidence to suggest optic disc pit maculopathy on the examination of the optic disc, no history suggestive of glaucoma or on the exam. Myotonic dystrophy could also cause retinoschisis changes centrally too, and the medications that Dr. Sivalingam mentioned. And the reason I included the last set of drops was just given the unilateral presentation, though these tend to cause exudative changes, but if the patient were to use drops just in one eye, that could also potentially be on the differential as well.
This is a good conversation. When I first see an OCT, and you see cysts, the first thing I think of is it thickened or not thickened, right? Cysts there are atrophic cysts, which implies a neurodegenerative process, something like MacTel and so forth. And then there's cystic thickening, which is what we have here, and that may or may not be exudative. So you're nicely describing this. When the cystic change is thick and relatively diffuse or broad, then you start to think about some of these non-leaking exudative processes. But A fluorescein angiogram would obviously help you to differentiate the two, short of any other associated features. But as you can see in this list here, you're assuming it's a schisis, and it probably is, and virtually everything on that list, except for the bottom one, would not be expected to leak on a fluorescein angiogram.
Thank you for that, Dr. Rigolo. Regarding the patient's history, the patient denied any prior ocular history or issues with nighttime vision. There was a history of very well-controlled hypertension and hyperlipidemia, migraine headaches, and Graves' disease, all of which were well-controlled with the medications below. No positive family history that the patient had, and socially a very healthy lifestyle. So the diagnosis here was sniffer or stellate non-hereditary idiopathic foveomacular retinoschisis, which is a term that was coined in 2014 on a multi-center report of 22 eyes with foveomacular schisis. 16 of these patients were female. There was one male patient, and all of these patients had visual acuity of 20/50 or better throughout the course of the follow-up, with a mean visual acuity of 20/27. There was just one patient who had a decrease in vision from 20/20 to 20/200 across the follow-up course and had developed subretinal or subfoveal fluid in that case, which is an entity that's noted in schisis in general. The refractive status of these patients were mostly myopic. However, there were some hyperopes in this cohort, and 3 of these eyes had pre-existing vitreous separation, and 19 of the eyes had attached posterior hyaloid, just like our patient did, and the follow-up was more than 6 months. So sniffer alludes to this subtle radial spoking pattern seen at the fovea, giving it the stellate appearance that the terminology comes from. It's a splitting of the outer plexiform layer with relatively preserved visual acuity, as we've said, better than 20/50. And there is no positive family history in these patients and no association with the RS1 gene, which encodes for retinoschisin and is the cause of extinct retinoschisis. As I mentioned, these patients tend to be females, and obviously extinct retinoschisis is primarily or exclusively a male condition. And the majority of these patients present with unilateral presentations, though there have been reports of bilateral presentation. I found a report of a patient with sniffer who, interestingly, had resolution of the schisis lesions after the vitreous had separated. This is a 67-year-old female with a diagnosis of sniffer based on spectral domain OCT with a hyperopic refraction, good visual acuity of 20/40 in the affected eye, and approximately 16 months after the initial diagnosis had a vitreomacular adhesion release, and about 22 months after the presentation had almost complete resolution of the schisis changes with improvement in visual acuity and the metamorphopsia symptoms. And the patient denied any history of surgery other than phacoemulsification in that eye and did not use any carbonic anhydrase inhibitors. So this is how the patient had presented. The phaco was done at approximately 3 months from baseline examination, and as you can see in the left panel here, at approximately 6 months, there's release of that vitreomacular adhesion, and at 22 months, there's complete resolution of those schisis changes. The fellow eye, interestingly, had vitreomacular traction, no cystoid changes, and did undergo a vitrectomy. So this is our patient 6 years prior. He's probably not projecting very well, but had these spoke patterns at that time as well, which was the time of referral to us. And the OCT from 2015 up to now remains completely unchanged. The hyaloid face remains attached, and the visual acuity is still good. Our third case is a 10-year-old boy referred for an incidental finding in the right eye. Dr. Sivalingam.
So, wide field pseudocolor fundus photo of the right eye. Vision's 20/20. Media looks clear. Disc margin looks sharp. Cup to disc 0.2. Vasculature looks normal and coursing caliber. Macula looks normal. You have this nice nerve fiber layer sheen seen in younger patients.
I'm going to just show a higher quality photo of the macula.
Sure. Oh, yeah, so this looks different. So attention is drawn to this kind of oval hypopigmented lesion in the temporal macula. Appears to be either deep retinal or subretinal, because you can see the vessels overlying the lesion. Kind of retina adjacent to this, it doesn't look like there's any edema, there's no hemorrhage, and I don't see any other retinal hemorrhages or edema elsewhere. And left eye vision's 20/20. Media is clear, disc looks normal, vasculature looks normal and coursing caliber. Macula looks normal. Yep, and this looks relatively normal too. Nice nerve fiber layer sheen. And then fundus autofluorescence of the right eye. We can see in this area that we saw that hypopigmented lesion, you kind of see this kind of granular hyper autofluorescence with kind of these round foci of hypo autofluorescence in the center. And then out here, kind of these more punctate foci of hyper autofluorescence. And then horizontal OCT cut through the right eye. Vitreous looks clear. Sorry, on the infrared image, you kind of see redemonstration of this oval hypopigmented lesion. And then, again, vitreous looks clear. Nerve fiber layer looks normal. Inner and outer retinal laminations are intact. Choroid looks normal. Okay, and now we have a cut through that lesion itself. The overlying inner retinal layers are preserved, and then you see this looks like it's a thinning of the ellipsoid zone and kind of disruption here of the inner segment, outer segment junction here. And then the underlying RPE also looks relatively thin. And it almost looks like you have a little bit of increased transmission through the choroid here. And then it looks like a radial scan through that lesion, again, showing similar thinning of the ellipsoid zone, and then this disruption here in the inner and outer segments, and then, again, thinning of the RPE as well. And then OCT through the left eye looks normal.
What would you think about when you see such a lesion?
Yeah, so, this is a young patient. I'd want to know if there's any history of trauma. Certainly, like an old scar from trauma could look like this. Resolved commotio can certainly look like this. It's relatively hypopigmented, but you can think about things like chirpy. Certainly the shape and the location of the lesion and that kind of torpedo-like shape makes me think of torpedo maculopathy. Those would be the main things that
So for conditions affecting the outer retina, trauma, the lesion looks pretty characteristic for torpedo maculopathy, but chirpy, as you alluded to, I saw RPE hamartoma in the differential, and this doesn't look characteristic, but given the macular involvement and the deep retinal lesions, vitelliform is what I have on my differential. So our diagnosis was torpedo maculopathy, which is a single hypopigmented area in the macula. Oftentimes tends to be asymptomatic. Those patients may have some visual field deficits from the lesion. It's almost always characteristically temporal to the fovea and in a torpedo-shaped pattern. It's a rare congenital anomaly of the RPE that produces disruption of the outer retinal layers, first described by Drs. Roseman and Gass in 1992. And there are several other terminologies that this lesion goes by. And there's no systemic associations known with this lesion, and the pathogenesis, for the most part, remains unknown. though there are some speculations in this regard. There's some hypotheses suggesting that choroidal development anomalies or ciliary vasculature anomalies may lead to this localized non-progressive RPE lesion. Dr. Shields and colleagues in 2010 discussed this RPE development hypothesis, where it's known that fetal RPE cells increase in size from the aura to the macular region throughout the gestational development, and there tends to be a temporal bulge in the temporal macula with a relatively high RPE cell count around 4 months of gestation, and this evolves into this slight residual depression with normalization of the RPE cell count around term, and it's thought that torpedo maculopathy could be the result of a persistent defect in the development phase of the RPE at this location of the temporal bulge.
Yeah, that information comes from Barbara Streeton. Barbara Streeton was an ophthalmic pathologist. She lived in Rochester. She did a ton of work on the development of the retina and the RPE in the fetal tissue, because she had access to all preterm babies who had died for whatever reason. So she did a lot of study on the development of the retina. I think her work was just probably the biggest contribution that she had made was in this, the development of the retina and the RPE. So anyways, basically what she said was the RPE is really active just temporal to the fovea. And we speculated maybe that's why this defect tends to occur there.
Two points. Number one is, if you look at the image of most of these lesions, the tip is actually towards the fovea, so that's something to be aware of. Number one. And number two, although it's debated, I do make sure the pediatrician's aware of this. There are some people that report that there's some association with kidney disease and situs inversus, so it's just something to make the pediatrician aware of.
And how do you tend to follow up these patients?
I don't. I mean, I don't know if there's really much to do.
Yeah, they are not at risk for CNVM, but they can develop SRF. Rich McDonald had a nice case, and Pam Golshay with Lee Jan Paul showed a case. They were the first to publish on it. Localized subretinal fluid at the site of Torpedo.
Which is a great transition. I'll quickly go over some OCT classifications that have been proposed in this regard. So Wong and colleagues did a multimodal imaging analysis on patients with torpedo maculopathy, and they suggested a type 1 and type 2 differentiation of these patients. So the top 3 images here show attenuation of the ellipsoid zone and the interdigitation zone of these patients. And in the type 2, which is the 2 images down below, there is this cavitation of the outer retina and some excavation of the choroid, in addition to complete loss of the ellipsoid zone and interdigitation zone. So this is the study and the categories that they had. So what they proposed was, given that the age range was higher in patients with type 2 lesions, they suggested that these may represent different stages of the same disease and kind of an evolution across the decades, though there are younger patients that have type 2 lesions as well. There was also a mention of a potential type 3 lesion where there was excavation of the inner retina, degeneration of the outer retina, and choroidal excavation with a subretinal cleft, suggesting a different type or phenotype for this disease. And our very own Dr. Light also mentioned that there may be more of a gray zone regarding these categorizations as we might want to expect or have. And this is a patient who, when looking through the foveal part of the lesion, demonstrated clear type 2 lesion with absence of the ellipsoid zone and interdigitation zone. But when looking at the tail of the lesion, had some choroidal excavation suggesting type 2, but the overlying RP and ellipsoid was completely intact, suggesting that things may not be as clear-cut that one would have. As the attendings alluded to, these patients tend to have a favorable clinical course and no ocular side effects that need to necessarily be monitored, with a good visual prognosis usually.
One thing to keep...
Patients with no subretinal fluid, do they have a field defect?
So that was the subject of this study. Some of them did, some of them did not. And some patients without subretinal fluid also had a visual field defect.
All patients with chirpy will have a visual field defect. It causes, photoreceptor degeneration. I would expect this would too.
Okay, thank you.
When they did the big studies on Zika virus from South America, they described torpedo-like RPE defects in patients, but it was bilateral and multifocal. So we throw around this term torpedo maculopathy, but back in the days of Zika virus, that was one of the retinal findings in children who were born with Zika virus.
Interesting. Well, thank you everyone for your attention and discussion points.